All right, yeah, thank you for inviting me back this year. This is a passion project of mine and something I care deeply about, and goes more towards the survivorship part of cancer care. And so the topic of today will be penile rehabilitation, optimizing the recovery of erectile function after prostate cancer treatment. I have no financial disclosures or interest. So we're going to talk about how erections work, just to do some anatomy 101, talk about how prostate cancer treatments affect erections, and how to optimize the recovery of erections. And then we'll go into some questions at the end. So I am a fellowship-trained urologist. I did a fellowship here at Stanford in male reproductive medicine, and I operate and practice out of our Emeryville and Valley Care Pleasanton locations, but I do offer video visits as well. So just to start off with, this is a picture I took from my mentor back in the University of Washington, but essentially how erections work is that it's purely hydraulics, and that's all it is. And fluid goes in and doesn't go out, and things go up, or essentially. And so in terms of the anatomy of erections, how this hydraulic system works is that we have nerves from the pelvic plexus that stimulate this sinusoidal space of blood vessels in these paired corpora cavernosa. So that's these guys here. And these corpora cavernosa are surrounded by this thick sheath called the tunica albuginea, which allows the system to be pressurized. And so essentially, to go from here to here, we have some type of arousal, sexual stimulation, mental, physical, whatnot. The nerves then release nitric oxide that tells the blood vessels to start to dilate, and the smooth muscles start to relax in those blood vessels. Arterial blood goes in, and the genius part of how erections work is that as the arterial blood rushes in, the outflow or the exit for the blood is on the outer rim of these corpora, so that as more blood goes in, the blood can't get out very easily. So you have compression of the venous outflow, and then you have liftoff, erections. In terms of the anatomy of where these things are, you'll notice that this is the bladder, the urethra, this is the prostate, this is sort of the star of today's show, and these nerves are pretty much right there at the prostate. They are paired fibers on left and right sides, and it's a fine mesh network that are basically adherent to the outside of the prostate. Hence, when there's radiation, surgery, anything that tries to treat this gland here, these nerves have a risk of being collateral damage. And to talk about erectile dysfunction after prostate cancer treatment, we have to sort of acknowledge that this is a very difficult topic to study. Erections are subjective, they are very personal, they differ from person to person. And how someone's erections are after treatment depend on how high grade their cancer was or what their stage was, what treatments they had, even within the treatments, the experience of their surgeon or technician, the patient's age going into it, the patient's overall health going into it, and just how good their erections were going into it. And if we look at, and obviously there's subjective perception, which is a huge part of this. One of the larger studies that looked at erections after prostate cancer treatments was back in the 90s. So we have to take everything with a grain of salt. This is before HIFU. This is before sort of some of the newer radiation modalities. And this doesn't really take into account nerve-sparing status or other things. But it tells us sort of a natural history of what happens after treatment. And you'll see here, the top line is radiation therapy. The bottom line is prostatectomy, radical prostatectomy. And this is also before sort of the robotic approach was popularized too. So again, take that with a grain of salt. But in general, we find that over time, men's erections typically get worse. And with the radiation therapy, it takes a slower float down, and prostatectomy takes a deeper dive immediately, but then they recover to about the same point at 5 years. And at 15 years out, you can imagine some of these folks are 80 years old plus, so that what they report may not be as significant from the subjective personal standpoint. We talked about radiation recovery timeline, and there's just an age, if you follow anyone out, people without prostate cancer, people without these conditions, and you follow them 15 years out, I'm sure that the curves typically also look like that as well. So it's, again, hard to attribute what is prostate cancer treatment related, what's just natural history of just being on Earth related. However, there are some well-reported series about just in general what to expect after prostate cancer treatment. After radiation external beam, again, huge ranges. It all depends on how you ask them and when you ask them, but it can be anywhere from 30 to 70% Brachytherapy, slightly less, 5 to 51%. And after prostatectomy, it can be, the numbers aren't here, but they also range pretty widely too, anywhere from 20 to 60% or plus, depending on the surgeon, nerve spare status, grade, all that. And after focal therapy, this is still an emerging area of research, especially at Stanford, but the ranges can be from 11 to 45%. And again, if you are eligible for HIFU, that might mean that your cancer was not as high grade or as aggressive as if you weren't eligible. So that might just lead into the factors that confound studying erections. But what we do know, and this is sort of to take a step back, because I'm a big picture kind of guy, is that erections are sort of a use it or lose it phenomena. And how that happens in practice is that the nerves that are near the prostate may be injured or sort of paralyzed by being spared, by being radiated, by being removed in some cases. And so that leads to a downregulation of the signaling that the penis will receive from those nerves. The penis not being sort of regularly inundated with signals that say, hey, let the blood flow come in, let fresh oxygenated blood come in, that leads to that smooth muscle being sort of replaced by scar tissue. And that scar tissue replacing the smooth muscle tissue leads to what's called venous leak, which means that the blood can go in, but it still can escape out. So you never get quite the firm hydraulic effect that you would get normally. And then chronic impotence, meaning you haven't had an erection in 1 year, 2 years plus, can lead to penile shortening just because the smooth muscle that's more stretchy is replaced by the more rigid sort of scar tissue in place. And so to prevent this use it or lose it phenomena, urologists have looked at penile rehabilitation. Essentially, our goal is threefold: to allow you to have spontaneous erections again. If that's not attainable based on just how things have recovered, we try to improve your responsiveness to pharmacotherapy and to prevent fibrosis and penile shortening. And what I tell my patients is that you have to imagine your penis like a star runner, like a star track runner, and they suffer an injury that sort of knocks them out from running for a while. And you can imagine two individuals on parallel tracks, both with an injury. If one of them just sits on the couch for 6 months and doesn't try running again, and the other one goes to physical therapy, starts to sort of try running safely and under the guidance of a trainer, you can imagine which one might do better. Now, neither of them might get to that pre-injury state, but definitely you would bet your money on sort of the one that's more proactive in their rehabilitation to get better. So in terms of what's in our rehabilitation toolbox, what do we have? We typically have oral medications, vacuum erection devices, and intracavernosal injections. And these are sort of standard erectile dysfunction therapies in general, but that we utilize in a more regimented way. And just to briefly go over them, from the oral therapy standpoint, these are what the little blue pills, the Viagras, the Cialis. They promote vasodilation in the corpora cavernosa by allowing the signals that tell them to sort of stay relaxed to persist, and they don't degrade. Common side effects are headaches, flushing, upset stomach. Most people tolerate them just fine. If you have one side effect to one brand like Viagra, then we switch to the other one, then most people tolerate that much better. You can't take these if you have a history of sort of cardiac chest pain, or if you're on nitrate medications like nitroglycerin. The vacuum erection device is colloquially known as the penis pump, but basically this is a non-medicated option that forms a vacuum around your penis, and it mechanically pulls the blood into the penis. It can be battery operated or manually operated. And the side effects may cause some numbness or bruising. And it's a soft contraindication, so you can't really use them if you're on blood thinners because it can increase the risk of bruising because you're basically pulling blood into your penis and there's some blood vessels under the vacuum effect that can sort of be ruptured. But this is a good both penile rehab tool and just an erectile dysfunction treatment tool. I think that's underutilized. And then we have intracavernosal injections. This is the self-injection of a pro-erectile medication. It's generally an out-of-pocket expense, so it can be $200-something for a vial that you can use maybe 10 to 15 times. So depending on if someone's on a fixed income, this is a little bit more difficult to arrange. It requires refrigeration, so you have to travel with it. You have to keep it in a cooler bag. But this works. This is sort of one of the bigger guns that we use. And one of the things I try to counsel people out of is a needle phobia. They hear about, oh, I'm injecting my penis, no way. But then I tell them, at least try it, because sometimes the results are so phenomenal that they're like, oh, I'll do this little prick to get the results I want. There's a small risk of scar tissue at the injection site, so we just tell people to alternate injection sites, left and right, left and right. And just from the diagram, we avoid the nerves at the top and the urethra at the bottom. So we tell people to inject along the sides here. And it's on the shaft. So people also worry that they're injecting it into their head, which is very sensitive, obviously. But no, it goes into the shaft. And so our approach here, which has been adapted from similar protocols across the country, is a pretty standard regimen of we use daily Cialis, on-demand Viagra, a pump, and injections. And we'll go into sort of the timing of everything. And I think these slides will be recorded, and if you have to take notes, they're available. So daily Cialis, we can even start 2 weeks before prostate cancer treatment. And this basically helps preserve smooth muscle health, and in animal studies, it has been shown to decrease scar tissue formation within the penis. We think just because it sort of keeps a little pilot light of a signal going to the penis during this process of recovery. And we continue it basically right afterwards. The minute you get home, you can go back on your daily Cialis, so there's not much of a break in this. And then 1 month post-treatment, if you've been taking the daily Cialis and you're still not getting any functional erections, we're pretty aggressive about this because we want to get those erections back as soon as possible. So we'll add an on-demand Viagra as well. So you'll take a daily Cialis, and a couple times a week with intercourse, with masturbation, you'll take a full dose of Viagra. Sometimes the pharmacies will say you can't combine these two, but it's been very safely demonstrated that the low-dose Cialis and the Viagra can be combined. But we have to monitor for those side effects: headache, flushing in the face, indigestion, those things like that. People ask me about the risk of priapism, which is an erection that lasts longer than 4 hours that you have to go to the emergency room for, but those are extremely rare with these oral medications alone. The next step is, this is the one that's, I think, to patients kind of like flossing. Like, you don't like to do it, you don't want to do it, but your dentist always tells you got to do it. This is one of those things here. The vacuum immersion device, so by pulling fresh blood into the penis and putting it on stretch that normally it wouldn't really have if you don't have erections regularly, it sort of allows the oxygen tension in the tissues to be healthier, and it preserves penile length. That's the biggest thing. You do exercises every day, so 30 seconds, you sort of have the vacuum activated, 10 to 15 minutes a day. People can start this before surgery just so they can get used to it, because you have catheters, you have potentially drains, you have other things after surgery or treatments that you don't want to try a new thing while other things are going on. And so after the catheter is removed, you can go back on the vacuum immersion device. But this is, again, one of those things where men that use vacuum immersion devices in this way after prostatectomy had a lower chance of losing an inch or more of penile length than people that didn't use it. So this is definitely the flossing will prevent cavities kind of thing. This is going to be the regular use of this can prevent penile shortening and improve erectile function outcomes. And then finally, if 3 months after treatment you're on vacuum device, you're on the Viagra, you're on the Cialis, and nothing's still happening, and you're frustrated, and you want to be able to have erections for penetrative intercourse, then we bring out the intracavernosal injection. We do an in-office teaching with one of our advanced practice providers, either a nurse practitioner or a physician assistant, and earlier use is associated with just better erections at 18 months. Again, my biggest caveat is, are these patients just patients that are more aggressive and proactive? Possibly. And it's hard to tease it out from the research. And so I've sort of interchanged some of these terms, pre and post, but essentially prehabilitation is just getting things started before the rehabilitation is actually necessary. And this has been studied before as well, where the patients that get into our clinics and our pathways and our regimens before their treatment tend to do better, measured at 12 months, or how their erection function scores are at 12 months. Again, likely due to patient self-selection. Who are those people coming in 2 weeks before their surgery or 2 weeks before radiation? Probably people that care a lot, that are sort of going to be gung-ho about these things. But the advantages are that we set expectations. I can't, you guys are ahead of the curve already coming to talks like these, but quite a few patients come to me after 1 to 2 years after their prostatectomy, and they'll say, "Oh, no one told me that I could have some penile length loss," and I'm like, "Oh, like that's it is a possibility." So we set expectations. We basically have someone else like myself on your team to just help. You have another ally in your survivorship journey. But we are also logistically able to set follow-up visits, so we have things that you don't have to make an appointment down the line. Just little logistical things that make life easier. We can start setting up now and then. We prescribe medications, so you don't have to wait for medications after your prostatectomy or prostate cancer radiation. And it just allows patient compliance to be improved. So people do ask me, like, what if nothing works despite the injections and everything? And that's where we talk about sort of our ace in the hole. This is a penile implant surgery. We place a prosthetic device in the penis. This has many advantages. It's a great solution and a lifesaver for many. or a sex lifesaver for many, in that it allows for spontaneity, so no pills, no timing, no equipment. You just sort of use it when you want to use it and stop when you don't want to use it. And it's highly effective, reliable. Patient satisfaction scores for those that sort of end up getting it are 90+%, 95%. And it's no impact on appearance and sensation of the penis. So orgasmic function and things like that are still present. Ejaculation after any sort of prostate cancer treatment typically is diminished. So I tell people that in advance. The limitations are it does require a surgery with recovery, and you can't go back to any other option. So you can't get the implant and say, oh, never mind, let me try the injections again. Because you can see where the space where the implant goes, it basically replaces the dysfunctional corporal tissues that were present that weren't allowing for erections. The implant longevity is about 10 to 15 years in the literature. So that's sort of why we say our motto at Stanford, or at least not officially, but in our clinic, is that as long as you have a penis, we can make it hard. And our confidence comes from the fact that we have these tools at our disposal. So future directions, people talk about this a lot. Radio ads, forums talk about stem cell injections or platelet-rich plasma injections. I would say there's no meaningful evidence, even in non-cancer survivor patients, for its use at this point. So it's in generally experimental. And last year's talk, when I talked about low-intensity shockwave therapy, I said there was no evidence as well. It's in the post-prostate cancer treatment realm. But this year, things are always changing, and we learn from our patients, we learn from our collaborators. But there are some little signals that there may be something there. Just briefly, what low-intensity shockwave therapy is, for those that don't know, is that it is a non-invasive, purportedly rejuvenative therapy for erectile dysfunction. It's been demonstrated to work best in mild to moderate erectile dysfunction. So the prototypic patient would be, Viagra works great, but I have a headache. Can I get off the Viagra? And this is a potential therapy that would benefit those patients. The limitations are that it's still at this point not covered by insurance. It's FDA approved. Sorry, it's FDA cleared, meaning it's safe. Outcomes have not had adverse effects on patients, but it's not FDA approved for ED treatments. Hence the lack of insurance coverage and off-label use. They require multiple in-office treatments, so if you're coming in from out of town 3 hours away, it may be difficult to get. And the clinical trial data is lacking, meaning it's hard to reproduce some of the results because every institution has their own effect. But essentially, we use focused shockwave therapy, which lets basically the energy penetrate deeper into the penile tissue. Be careful about some radio ads. They talk about their technologies are actual radial waves, and these don't go very deep into the penis and don't do anything. And the shock waves are basically applied to the penis. It's a probe that just delivers the energy, and it's done in the clinic, in the office, over a 10 to 15 treatment session. But why I bring this up, and I don't want to, this is not anything that is realistically going to be reproduced anytime soon, but a very recent South Korean study looked at 160 men from 2019 to 2021. They underwent bilateral nerve-sparing robotic prostatectomy, or open, but those are less common, in patients who had pretty good erectile function going into surgery. And this is the more elaborate part. But while they were in Korea, I guess they stay in the hospital sometimes for up to a week instead of the day surgery or outpatient sort of overnight stay here in the US. And in that 1 week, while you're recovering after prostatectomy with the catheter still in, a healthcare provider came into your room and delivered shockwave therapy to your penis, like on days 4, 5, and 6 of your recovery of your hospital stay. And they compared those patients with patients that just were on the daily Cialis. And at 6 months, it looked like the shockwave group did seem to fare better, but that was a pretty short follow-up. And this, I would just consider this to be continued, and that at this point, I would not recommend shockwave therapy routinely for its use, but just to know that the field is always evolving. Hence, these talks every year are very important, I think. So I want to leave plenty of room for questions, but the final thoughts are that erectile dysfunction and in some cases penile shortening can be a potential consequence of prostate cancer treatment. It is a use it or lose it mentality, so the more proactive you are, the more supportive your partner is, the better. Consider penile prehabilitation if you can, but definitely consider rehabilitation after the fact if you're able to. I think the fact that you're here today at this talk already means that you guys are probably prehabilitation-minded people, I think. And in general, cancer care now is very multidisciplinary, so just consider to add a urologist like myself who specializes in erectile dysfunction to your care team. And so we can handle all the sexual health information, and your other doctors can handle the I don't know, Gleason score, PSA, all that stuff. And for people that get care at Stanford, it's an easy referral. They can just send me a message essentially, and we can squeeze people in before their cancer treatment date. Beforehand, before I came a couple years ago, people would be referred for prehabilitation, but they wouldn't get into the clinic until maybe 2 months after their surgery. And so we've sort of fixed that by having more available video visits, so we can sort of squeeze you in for a full counseling and setting up of all those appointments and medication prescriptions and so on and so forth pretty easily. And that's it. So that's my talk about penile rehabilitation. Thank you for letting me speak.
Thank you so much, Dr. Chen. And I do want to just emphasize that he really does get back to you immediately. When I say I have a patient who's going to have surgery in a few days, next thing I know, the patient's already been seen. So he really gets patients in, whether it's a few days before or even after. It's been a great team. So we do have a few questions. Please be sure to write down on the cards, and we'll go ahead and pick them up. Allison?
There are a couple questions in the live chat. Are there any devices or treatments after end of hormone treatment?
So for people that undergo androgen deprivation therapy, I'm assuming, that have erectile dysfunction, the regimen is still pretty similar. There are no sort of devices besides the vacuum erection device, but all the treatments are sort of in play for those people. If they haven't tried medications, we would try them. If they tried them at lower doses, we'll go to max dose. We'll try vacuum erection devices. We will try injections as well. And again, shockwave therapy, I'm still not a big believer in it post-prostate cancer treatment yet.
And then is Viagra or Cialis an option for people on ADT?
Yeah, it is. Barring any other cardiac issues, it should be.
What efforts have been done to help support the restoration of a man's mental and emotional health after post-radical prostatectomy ED?
That's a huge one that I actually, a lot of my patients do express some frustration that there's a lack of sort of specific groups just for sexual health survivorship, because there's a lot of prostate cancer survivorship groups that you can find online and forums, but some of the Facebook groups have been helpful, but there hasn't really been any big ones that sort of support this explicitly. I do know that we do have, I think one of the talks today was about sort of mental health and survivorship, that seeing a therapist or a sex therapist can be helpful. We have a list of sex therapy resources that we provide our patients that could use that as well. But definitely, I think that's one area that we could do better, having sort of just a support group just to talk about these very intimate and sometimes embarrassing for some patients questions to discuss, and I think so.
Yes, and there is a breakout session on tools for resilience, mental health, and well-being with Ben Anjo. So
yeah, perfect. So if that question asker is interested, that'd be a good breakout session too.
Another question. Mm-hmm. If penetration is not occurring at present, will radiation have other adverse effects?
Radiation has I think the radiation oncology talk can discuss the side effects of radiation in general in terms of bladder and bowel and other things, but patients with radiation treatment, if they go into radiation with poor erections, then there's a potential that whatever you are getting, any partial erections may get worse after radiation. And the risk of penile shortening is also there as well.
Okay, last question. Is there an age limit to getting an implant? Are you ever too old to get one?
So it's more how old, quote unquote, your body is, I suppose. There's very healthy 75, 80-year-olds. There's very unhealthy 50-year-olds out there, and so we sort of take it on a case-by-case basis. There are also other implants available that are, I didn't go over them today just for time's sake, but there are things called malleable penile implants that are sort of less invasive and the surgery is less onerous that older patients may benefit from, and I regularly offer everyone all the options at our visits.
Thank you so much.
Thank you so much, Dr. Chen. And just a reminder, one of the booths outside does have a penile implant, so you can actually go over and take a look and see what it is and ask any questions you have.